as an imager, when you read coronary calcium scores, you have to pick a race for your patients. It's either white, African American, Hispanic, or Chinese, but there's really no representation for South Asians. Part of what we really wanted to do was look at the sex-specific distributions of coronary artery calcium in South Asians and kind of look at what those normalized percentiles are.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. It's another Monday. Thanks for tuning in. My guest on today's show is a special connection. She graciously agreed to be on the advisory board for my nonprofit, makeadent.org, through which, we host this podcast platform. She has, I view her now as an expert, as a content expert on the topic of South Asian heart health. She has worked incredibly hard to develop a registry in her organization in Texas, which has accrued impressive data on South Asians, and she's publishing seminal papers out of that registry. I'll let her speak more. I don't want to take the spotlight from her. So with that introduction, our guest on today's show is Dr. Anandita Kulkarni. She is a preventive cardiologist. She is the Baylor Scott and White, the Heart Hospital in Plano, Texas. And, she has been writing seminal papers even whilst being a fellow. I know we didn't cross paths, but we sort of trained under similar mentors or same mentors. And so, we were sort of cut from the same cloth, as they say, in that aspect. And I couldn't be happier that she is on Parallax, and she's going to talk to us about a topic which is dear to me, is one of the central tenets for makeadent.org. And, she's been a part of it. So with that introduction, without much further ado, Anandita, thank you so much for doing this for us, and welcome to Parallax.
Thank you so much, Ankur. It's such a pleasure to be here.
Oh, it's pleasure is mine. And, thanks for doing this. Again, I know we've been trying to get this episode recorded for some time now. So Anandita, let me start by asking you, what, other than the fact that we both are South Asians and, we share that ancestry, what prompted you to take on a project like your registry at Baylor Scott and White, which is now, as we know, is contributing to the literature in this literature scant or data-free space?
That's a really interesting question. I never, had this all planned out. It just so happened that after I finished my fellowship training and was applying for jobs, I happened across, Baylor Scott and White, the Heart Hospital, Baylor Plano. And it just so happens that the hospital is down the road from where I went to high school. So I had the opportunity to move back into my home community and take care of, people in my own community, including the South Asian communities. I kind of jokingly say that I run the uncle and auntie clinic because a lot of our patients are family friends and things like that. And I think there was a lot of, desire to do something not only directly for our specific community, but really to just go above and beyond and impact patient care, nationally and hopefully even internationally. And so, really had the opportunity to leverage some of the assets of the Baylor Scott and White healthcare system. So as you may know, it's one of the largest nonprofit healthcare systems in the state of Texas, and I think also within the United States, comprising of about 51 different hospitals. And so I had this great opportunity to leverage that data to identify patients of South Asian ethnicity to put together this registry.
First off, congratulations for having the insight to do this, sort of system-wide for your health system. And I know that Texas is one of those states where, the concentration exists, where when I say concentration, the concentration of South Asians exists where you can, create a meaningful registry with longitudinal follow up and sort of follow these patients or even healthy subjects. And I know you're going to talk to us more about Dilwale, which is the name of your registry. For someone who's listening who wants to emulate what you've done, Anandita, with your healthcare system, where do they start? I mean, who do they speak with? What are the nuts and bolts for doing this? Because you sort of have done this with aplomb and very successfully. So if someone who's listening who wants to sort of establish a similar registry and contribute to this space and contribute to the literature and collaborate with you so that we can garner more data on our people, how do we do this?
Yeah, absolutely. Our biggest challenge initially was actually trying to figure out how to identify patients who were of South Asian ethnicity. If we look at our EMRs, it's not very easy to glean. In our healthcare system, we use Epic, and it doesn't automatically identify patients who are specifically South Asian. So this was the biggest lift actually for initially getting the registry up and running. We actually used a validated surname list from India of, kind of popular South Asian last names. And then we also sub-selected all of the patients who identified as being Asian. And then we used multiple iterations of two independent South Asian reviewers to identify the patients that were South Asian. And the two reviewers had to have concordance in order for us to include the patients in the registry. So that in and of itself was probably one of the most challenging things to do. Outside of that, it was, we were able to pull a lot of the data from the electronic medical record. Funding was a big thing. So we were, grateful enough to receive philanthropic donation from Satish and Yasmin Gupta, who are a, South Asian family in our community. And that's really what helped the registry, get up and running.
That's Anandita. How long did it take you? Because that as you said is quite the lift. I mean, when it comes to regulatory process around, even coming up with a list of surnames and getting that validated. I mean, did you have to put an IRB together before you even got to this step, or this was sort of the first screening steps where you sort of got in touch with the informatics team in your health system to help you through this process?
I guess I glossed over that part. Yes, we did. We put together an IRB. To be honest, it took us a good part of 2 years just to get all of the kind of the groundwork for this up and running. And I had a lot of support from our hospital chief of staff, Dr. Michael DeMaio, who is a, very strong advocate for South Asian cardiovascular health. And then also, what is not represented here is probably the hundreds and thousands of volunteer hours from our students. We've got a really, really strong research team. We're very well equipped. And so, all the work that our data scientists put in just to get all of this off the ground. So yes, we followed all of that research, all of those research protocols.
Yeah, excellent. So, tell us about, obviously we've seen papers come out of the registry now, which is, sort of the fruit of the effort. But as you mentioned, it takes a lot of effort, a lot of sustained effort and focus to get this off the ground and, to get to a point where you're at now, where you have data to share with, colleagues, not only nationally, not only for second generation South Asians, but even for South Asians back home in India. Tell us about the health of the registry now and where the registry is now, and how do you see it, accrue more knowledge and share it with our community and with the rest of the world.
Yeah, absolutely. So our initial investigation was really to characterize our population. So we have over 31,000 individuals in the registry. The data was retrospectively collected. And about 48% of those individuals are women. So gives me great pride that women are well represented, as often they're not in our clinical studies. And the goal of our initial investigation was really to assess the prevalence of atherosclerotic cardiovascular disease, premature ASCVD, and the contributing risk factors among this population, just to kind of see what is the prevalence of all of these risk factors. And so we were able to kind of put together some of our initial findings that were published in JACC Advances. And we found that the prevalence of atherosclerotic cardiovascular disease was about 7% in our population. And among those who had disease, there is a very high prevalence of uh, hypertension, hyperlipidemia, diabetes, and a family history of heart disease. Many of these risk factors are preventable and treatable with primary prevention. So it just gave us the optics of how we can potentially leverage our preventive interventions in these patients. And it also just gave us a good idea of, kind of what is this population that we're working with, within our healthcare system. And then we've, kind of taken this a little bit further. Earlier this year, we published a paper in JACC Advances looking at the presence of coronary artery calcium. So we had the opportunity to take the patients from Dilwale who had a coronary calcium score and hybridize our data set with Masala, which is, another large registry of individuals who are prospectively collected. And we put together about a little over 2,700 South Asian individuals who had coronary calcium scores done. And the interesting part of this is, as an imager, when you read coronary calcium scores, you have to pick, a race for your patients. It's either white, African American, Hispanic, or Chinese. But there's really no representation for South Asians. And so part of what we really wanted to do was look at the sex-specific distributions of coronary artery calcium in South Asians and kind of look at what those kind of normalized percentiles are. And some of the interesting things that we saw were that approximately 25% of South Asian men between the ages of 33 to 45 years actually had presence of coronary artery calcium, which oftentimes, coronary artery calcium scoring doesn't even start until the age of 45 years. So we're starting to see, calcified plaque build up quite early on. And the probability of having a calcium score greater than 0 exceeded 50% in our South Asian men between the ages of 50 and 55 years, and in South Asian women between the ages of 60 and 65 years. And so it's really given us, a little bit of a deeper look into kind of what that presence of calcified plaque is in our South Asian individuals. We're working on taking this a little bit further now and looking at AI-guided plaque quantification among our patients who've had coronary CT to see, not only the calcified plaque, but looking at, other parameters like non-calcified plaque, low attenuation plaque, to see if we can learn a little bit more about this.
That's fascinating, Anandita. I think, I'm going to ask you this question because this has sort of come up. This is some of the work, we published, Dr. Virani and I published from the PQIP registry. And certainly Salim Yusuf and other investigators have published from the worldwide registries in that the onset of atherosclerosis, which we call premature atherosclerosis, is existent in South Asians. And I think it sort of, when we were putting together the documentary, which you may or may not have seen, The Brown Heart, and when the directors of the film, Doctors Joshi and Joshi were interviewing Dr. Yusuf, he said that he's come full circle in that he may have started to believe that the onset of atherosclerosis may not be premature in South Asians, and I'm yet to come across data to support that. To support that the onset is not premature. To the contrary, like we've believed and what the data have shown, it is premature. And so, my question to you is twofold: does do your data, the data from Dilwale, validate that the onset is indeed premature? That's question number one. And question number two um, is this a phenomenon which is limited to first generation South Asians who have immigrated from from India or from South Asia, extending beyond India, Pakistan, Bangladesh, Sri Lanka, Nepal, and the remainder of the countries in the Indian subcontinent, or you think it has percolated to also manifest in premature atherosclerosis in second generation South Asians?
So for your first question, I think the data in our coronary artery calcium paper, suggests that, atherosclerosis starts early in South Asians, given that 25% of South Asian men between the age of 33 and 45 years had the presence of coronary calcium, and that likely, progresses over time. I think it's a really interesting question that you ask about generational, differences among South Asians, whether, with regard to patients being first or second generation immigrants. Unfortunately, that's, one of the limitations of our registry is that our data were retrospectively collected. So we don't have granular data on who's first generation versus second generation. We also don't have disaggregated data, which, I think has been a little bit of a challenge, but something that we're working on. We know that there are differences in the prevalence of heart disease, depending on your country of origin, even within South Asia. So we can't necessarily lump everybody into the same category. One of the things that we're doing to kind of remedy this is we are working on building a prospectively collected South Asian, cardiometabolic consortium with a number of collaborators around the country, where we are going to enroll our South Asian patients in clinic. And we're going to have them fill out a questionnaire that, addresses all these questions, your country of origin, what generation immigrant you are, what your lifestyle practices are, what your dietary patterns are, things like that, to really delve into the questions that are not very easily gleaned through the electronic medical record. So hopefully, if everybody stays tuned for a few more years, we'll have some really good data on this.
Yeah, excellent, excellent. Anandita, tell us more about some of the conversations you've had with, uh, healthy subjects or patients who've become part of Dilwale. I mean, I think a lot of the effort, right, in establishing a registry like this and sort of seeing these patients in clinic and longitudinally following them is also to influence behaviors and sort of influence how they live their lives. We know epigenetics plays a crucial role. So, as much as we may not be able to alter the genetics, if we can change the epidemiology in terms of fostering healthy behavior, whether it comes to diet, whether it comes to exercising and promoting movement, in our culture, which you and I have talked about this, offline. A lot is focused on great food with either movies from our cinema, which we all love, Hindi movies or movies from other regional languages even, and like sitting and watching cricket and eating great food. How have you been able to foster healthy behavior or behavioral change and sort of have those conversations which have stuck with patients or with communities, um, South Asian communities?
Yeah, I mean, as a preventive cardiologist, I think one aspect of it is addressing and treating the risk factors, right? And part of what we've learned is some of our South Asian patients really need to be screened a little bit earlier and more aggressively than our general population. For example, when it comes to obesity, we know that the World Health Organization has lower BMI thresholds for Asian individuals, and that should prompt screening for other comorbid conditions like diabetes and metabolic syndrome at a lower BMI threshold. So we're, implementing those changes into our practice. And like you said, the other part of it is very much lifestyle. one of the things that I was sad to hear was that we are the least physically active ethnic group in the world. And, and I think that there's, a variety of reasons for that, maybe some cultural things and, you know, for women, it's a little bit challenging, especially, because of, it may not be socially acceptable for women to exercise in co-ed settings, and there's more barriers that way. And so one of the things that we do for exercise is I counsel everybody on exercise at every visit. Growing up, I was never raised to be athletic. And it wasn't until I learned more about heart disease that I started exercising regularly. So about 5 years ago, I trained myself how to run. I trained myself from never being a runner, trained myself how to run 5Ks and 10Ks, and started lifting weights with my personal trainer. And a lot of that, I share a lot of that personal story with my patients because part of what is motivating is seeing that, I'm right beside them doing the same thing, and I go through the same challenges that they do in their lifetime. So part of it is identifying with each other. The other part of it is diet, right? And I think you alluded to this. I think we've got some great food. And I always ask my patients, what do you order at a desi restaurant that's healthy off the menu? And everybody often just kind of smiles back at me because we all know that everything is, fried or in some sort of like cream gravy or really greasy or things like that. And so we had this, great conversation about how the traditional South Asian diet has westernized with, Western acculturation. And so things that we wouldn't traditionally eat in India or Pakistan or, our home countries, we're, starting to eat now. I was born and raised in the United States. However, I remember when I visited my grandparents in India, we would always use, like fresh subjis that were delivered to our home every day. Everything was cooked fresh. I mean, we almost never ate out. There were no like fried foods, fast food, snacks, and things like that. And, with kind of Western acculturation, we're eating out a lot more, incorporating a lot of the Western diet, which is high in fat. Our foods, even at our desi restaurants, use, like fillers, heavy cream, lots of oil. When foods are fried, they're reusing the same oil to fry them, which increases atherogenicity. So we have discussions about all of, those kind of different parameters and how we can kind of, by cooking meals at home, using fresh fruits and vegetables, whole grains, kind of going back to that traditional kind of healthier version of the South Asian diet, we can kind of mitigate some of these lifestyle factors. Sort of putting it all together, though, in our preventive cardiology clinic, the way that we integrate this is that, the patients will come and see me, and then I have a desi dietitian that will sit with them and kind of coach them one-on-one. She'll even build them an individualized meal plan, kind of balancing out all the macronutrients and things like that they need. And then on top of that, for people who are interested, we actually have an exercise program where our patients will go to our cardiac rehab facility and meet one-on-one with a cardiac exercise physiologist. It's kind of like a personal training session, but the goal of that session is to learn how to exercise and meet those guideline recommendations, often doing a combination of cardio and strength training. And we want that routine to be something that they can replicate in their day-to-day life. And so, beyond just telling them, we try to show them. Our dietitian also walks them through the heart hospital cafeteria. They pick out a heart healthy meal together, and they do their dietitian consult over a meal together. So it's, a lot of show versus tell. And that's helped us make a lot of progress with our South Asian community.
Yeah, excellent insights. Yeah, I think what is empowering for patients is if you can share your own struggles with them, and your own methods, with regard to what has worked for you, when you've tried to imbibe these healthy practices into your own routines. Um, that I found to be, it's relatable to patients, and then it's also empowering. That this is, here's my doctor, and he's trying to do the same things that he's asking me to do, and there is challenge, and yet he or she has been able to do it, so we should be able to do it as well. So thanks for sharing that tip with our listeners. How do you see how do you see this landscape progress? I mean, and when I ask this question, what I'm alluding to is, well, I mean, I think first off, I think it'll be helpful for our listeners to know um, as to what constitutes a visit in a South Asian clinic. So if someone, say for example, someone in their early 40s comes to you, South Asian, has a family history of premature atherosclerosis, is exercising, eats a healthy diet, and wants to know his or her risk, and wants to have a consult with you, what all does he or she go through in a clinic in terms of laboratory testing and in terms of counseling?
A lot of it is individualized. We look at all the basic things, right? Whether they have hypertension, diabetes, we look at their cholesterol. If they don't have a lipoprotein A level or ApoB, we'll often check one. If they are of the appropriate age, I utilize a lot of coronary artery calcium scoring. I think it really helps be very objective about the findings and level the playing field. If they're too young for coronary calcium scoring, then we really focus on optimizing any of their risk factors as well as, medically or with lifestyle, depending on kind of how we perceive their risk to be based on, family history and what they're currently doing. But I'm, for the patients who are eligible, I am very liberal about using coronary calcium scoring, personally, because it gives us, objective metrics to look at. And second of all, I've found that, being very clear with patients about this is how much calcified plaque you have or don't have at all in your coronary arteries can be really motivating for them to improve adherence to medical therapy and the treatment plan.
So a couple questions here. What is your age cutoff in South Asians to get a calcium score? And if you can walk us through totality of calcium score, from like 100. Okay, so less than 100. I mean, I know ideally it should be zero, but say it's less than 100. Then between 100 and 100 and a 300, then between 300 and or 300 and above. Or, if you have different thresholds for intervention, then educate us about those thresholds. Because again, this is a question that I get commonly asked. I mean, a lot of these patients, despite being completely asymptomatic, are put through selective invasive strategy, some sort of a stress test, which I don't entirely agree with that strategy. And then there is some downstream testing, and the patient is completely asymptomatic at baseline. So how do you manage, and this is obviously extrapolates to all other ethnicities and races. But I think a good discussion point, certainly for South Asians in terms of age cutoffs and tertiles for managing calcium score.
Yeah. Wow. That's a challenging question. There's a lot there. So I want to first address the fact that, if we're kind of looking at the indications, a calcium score is supposed to be an asymptomatic screening test, right? So by definition, we're looking at asymptomatic individuals with calcified plaque. So there has to be a very clear reason for me to do a stress test on them subsequently, right? If there's documented symptoms, I don't think that any particular calcium score should just automatically reflex to invasive testing or things like that. So I think, first and foremost, we have to be clear about what those indications are. With regards to age cutoff and the threshold at which we treat, I think that becomes a little trickier. I'm pretty liberal about offering coronary calcium scores to patients ages 40 and above. And if they're below 40, I often think about that a lot if I'm going to do it, because there is a higher prevalence of soft plaque in our younger patients, and I wouldn't use a zero calcium score in our younger patients to de-risk them. So I'm very clear about that discussion up front, that if you do have risk factors for heart disease, then we will continue to treat them even if we do get a calcium score on you. With regards to, the cutoffs, looking at a calcium score of zero, in general, if risk factors are still out of control, then I still offer medical therapy, we sort of have a discussion about indications, risks, benefits, how aggressive they want to be about primary prevention. What are their other comorbidities, risk factors? What is their family history like? So I've certainly treated a fair number of patients even with a coronary calcium score of 0. Now, when we get into those higher calcium scores, sort of that gray area between 1 and 99, it really depends on their age and what their percentile calculates out to be. I do lean towards being a little bit more aggressive about prevention because truly, the earlier you start, the better off you are long term. Now, for our highest risk patients, those with coronary calcium scores above 300, we formally give them the diagnosis of coronary artery disease. And in those situations, I am very aggressive about trying to optimize all of their modifiable ASCVD risk factors. And I'm particularly aggressive about lowering the LDL cholesterol. So these are the patients that we are trying to maximize high intensity statin, adding on ezetimibe if needed, adding on additional medical therapy like a PCSK9 inhibitor, and or bempedoic acid and things like that, really targeting that LDL cholesterol, ideally below 55. And I think there are some data in our South Asian patients that in some instances, for very high risk patients, we target an LDL cholesterol below 30. So the level of kind of how aggressive we are is oftentimes a discussion with our patients in terms of what we glean their perceived risk to be and how much they want to do with this.
Yeah, wow. I mean, LDL. I mean, look, I've had patients with LDL in their double digits and single digits, and I think they do just fine. I think there isn't any safety concern. It's a good segue for me um, to ask you this question, and that question is, Anandita, that in South Asians, what has your experience been? When it comes to patients tolerating high intensity statin therapy. So, in someone in whom, based on the calcium score in an asymptomatic patient, relatively young, you want to start a high intensity statin. Do they tolerate it just fine? Because my experience, at least in the indigenous population back home, has not been encouraging.
Oh, that's interesting. I have not perceived any side effects that are, any more prevalent than our kind of general population. I mean, my standard approach though, if somebody has side effects, is we ask them to call us immediately and let us know. We'll ask them to hold their statin therapy for 2 weeks to let it wash out of their system. And then based on how they felt, we'll ask them if they feel comfortable. If we're unsure as to whether the symptom was related to the statin or not, sometimes we'll offer them the opportunity to start at the same dose again to see if they elicit the same symptoms, or we may offer them a lower dose or a different statin. In the overwhelming majority of my patients, though, I have not had trouble getting them on at least some statin therapy. And sometimes you can't hit that high intensity dose, but then I'll pair the statin, like a rosuvastatin 10 milligrams a day with an ezetimibe 10 milligrams a day. And that combination therapy can often help bring them, down enough. So we've got some tricks in terms of how to address that. I think the bottom line, though, is we want to put out the message that, I don't want you to be on this medicine if it's causing you to have side effects. And I want you to let me know immediately so that we can treat you effectively, but you can also retain your quality of life and do all the things that you need to do without having, myalgias or, whatever else.
Yeah, and as an extension to life, I'm sure as a preventive cardiologist, you probably feel a lot of these questions from patients, even patients you see in the South Asian clinic as part of the Dilwale Registry. Is have you had any questions on GLP-1s? I'm tempted to ask because it's sort of like, I'm sure you have patients who are asking you prescriptions for GLP-1s.
I'm pretty aggressive about prescribing those GLP-1s. So I feel like a lot of times before they even ask me, we're having a discussion about it, especially given the high prevalence of diabetes, and other sort of, metabolic syndrome related things. So I'm quite aggressive about using it. And I feel like it's really worked well in a lot of our DAISY patients. One of the things that the GLP-1s target is visceral adiposity, which is what a lot of South Asian individuals are predisposed to, and that leads to other downstream consequences of the prediabetes and the diabetes and metabolic syndrome, the high triglycerides, all of those things. So I think it actually works really well for our South Asian patients. I think I've probably proposed it more so than my patients coming in and asking for it.
Wow, no, that's insightful. That's also great to hear that you're sort of proactive about GLP-1s, because they do have they do have their space in the armamentarium, and I think it's important to keep diabetes at bay, particularly in our people. It's once you have diabetes, I mean, the burden of atherosclerosis and the acceleration of atherosclerosis that I've seen, in South Asians is just it's precipitous. I mean, it's mind-boggling how quickly the vessels get diseased. Well, I mean, Anandita, look, this has been a fascinating conversation. Congratulations to you on Dilwale. Congratulations to you for all the amazing work that you're putting out. I mean, some really high impact, really well done papers. It's inspirational to see how far Dilwale has come, how far your career has come, within this space. And, it's heartwarming to see that, second generation South Asian has done incredible work in advancing knowledge and advancing care for for our community. Do you have any closing remarks for Parallax? Any closing remarks for Dilwale?
Um, Yeah, I mean, first and foremost, I really, really want to thank our collaborators. Jaydeep Patel and Priyanka Satish are some of my good friends. And, I'm eternally grateful to them, because when I first started thinking about this, I mean, they probably spent hours on the phone with me, just kind of going back and forth on how we would build this registry. And I also really want to thank not only the leadership at Baylor Scott and White, the Heart Hospital Baylor Plano, and the Research Institute, but also the research staff. My project manager, Dr. Swapno Gupta, essentially now runs this registry, which is, rapidly becoming a full-time job. And it isn't without the help of so many of our staff and our collaborators, most of which I've neglected to mention, but I won't in the interest of time. This would not be possible by any means without their huge lift in this registry.
Excellent. Well, congratulations again, and keep up the great work. And, I look forward to working with you in some capacity and collaborating in some capacity. And, for our listenership, do send your feedback to us. If you have any questions for Dr. Kulkarni, please email them to me. You can email them to her directly. We'll make sure that her email is listed in the show notes. And if you haven't, and we certainly will mention papers from Dilwale, which I think have come up during the course of our discussion for this podcast episode. But do follow her work. It's incredible work. Both Dilwale and Masala 2G. That's Dr. Kanaya's work. I think these are fabulous registries and some incredible contributions to the literature when it comes to South Asian heart health. And thanks again for tuning in. Thanks again for listening. And until other Monday, have a good day or a good evening, everyone.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.